right. Good morning, everyone, and welcome to the Austin Ryan White Clinical Quality Management Committee meeting. Today is Thursday, June the 15th, and we welcome everyone and thank you for joining us. I have dropped the agenda in the chat for those of you who may not had an opportunity to retrieve that from your email. I've also started including those a couple of days in advance to the calendar invite. So if by chance you missed the email, hopefully it's in the calendar invites. And then we've also posted those on Basecamp. All right, so in essence of saving time, if you could just drop your name, the organization you're with, and your title in the chat so we can make sure that we record everyone who is here with us today. And then I'll do quick introductions of the collaborative research teams. We have some guests with us and colleagues from my side, and then we'll move on to the APH staff and the Ryan White staff at Austin Public Health. So good morning, my name is Thomas Rodriguez-Shucker with Collaborative Research, and we are the consulting group for the APH and HRAU. All right, and I'll pass it to the next person I see, Octavio.
Good morning, everyone. Thanks, Thomas. Octavio Posada. I'm the Deputy Director for Collaborative Research, EHC initiatives. Good morning.
Great, thank you. John?
Hello, everyone. John Sapero. I am the Director of Ending the HIV Epidemic Initiatives for Collaborative Research, and I'm joining you from sunny and soon to be warm Phoenix, Arizona.
Awesome, thank you, John. Andy?
Good morning, everyone. Andy McCracken, Director of Data Analytics with Collaborative Research, and I hope you're all keeping cool and will be for the next week or so. It's going to be 100+ down there, so.
All right. Andy's only saying that because he's in Chicago right now where it's cool weather. So he's bragging because he's not in the heat. All right.
I'm Cliff Barnett from Cleveland, Ohio. I'm a consultant in Planning Council support for Collaborative Research.
Thank you, Cliff. Nathan.
Nathan Holcher with Collaborative Research, Director of Client Operations, and I live here in Austin, Texas with y'all.
Yeah, so he understands the heat as well. Derek.
Hello, everyone. I'm Derek Jackson with Collaborative Research, Deputy Director of Ryan White Client Services, and I'm joining you from Norfolk, Virginia.
Awesome. And Melissa.
Hi, everybody. Melissa Rodrigo, Director of Strategy, Innovation, and Collaborative Research, and I'm joining you from Cleveland, Ohio.
Awesome. So we've just about brought our entire team because we have some announcements and things that are coming up soon that we were going to make today. And you probably saw the flyer attached to the agenda as well. We just kind of want to reiterate that. And I will pass it to my colleagues at the HRAU staff, starting out with Ken.
Good morning. Thank you all for being here this morning. Big welcome to all the CR staff that doesn't normally attend these meetings. And yeah, I'm the acting unit manager for the HIV Resources Administration Unit. And I will pass it over to Jennifer.
Good morning, everyone. My name is Jennifer LeBlanc, and I am the Clinical Quality Management Coordinator with the HRAU. And like they said, just trying to stay cool over here in hot Austin. I will pass it over to Raju.
My name is Raju Gimire. I'm Research Analyst in Austin Public Health, HIV Resources Administration Unit. I'll pass it over to Sherry.
Good morning. My name is Sherry Lyles. I work obviously with HRAU, and I'm the data manager. And I will pass it to Erin.
My name is Erin Brown, and I am the Part A Grants Coordinator in HRAU.
Perfect. And I think that may be all your HRAU staff. All right. Okay, awesome. And so just to save time, if everyone else, if you don't mind, not that you're not important, but just wanted to make sure you knew your staff from HRAU and Collaborative. If you would just drop your name and title, which it looks like just about everybody has, we appreciate that. We will go ahead and get started with our packed agenda today. So Jennifer, I'll turn it back over to you if you have any more welcome comments and introductions.
No, I think that is it. I think we could jump right on into the year 2023 quality improvement projects.
Sure. All right. So thank you all for getting those in. We know they kind of dropped off everybody's radar since we took kind of a month off in June. So we appreciate you getting those in. And so the reason we brought some of our staff on is our colleagues, Derek and Melissa, will be reviewing your quality improvement projects that you have submitted. And we'll be utilizing this form to kind of give you feedback on your quality improvement projects. And so as we look at it very briefly, we'll bring some of this information from your projects over to this form, and we'll kind of annotate if it exceeds the expectation, meets the expectation, or if it's an unmet expectation. We're asking that as you receive your review and feedback, if you have an unmet area that needs to be updated or reworded, that we'll work with you in resubmitting those and working the logistics out of how that needs to kind of adhere with our policy clarification notice 1502, which we've listed a little bit here above for your reference. But we'll go through all of the primary drivers, secondary drivers, your aim, rationale, and problem statements to make sure they align with the projects that you're working on, and to make sure they're succinct enough that they're measurable and attainable, right? Because we want to make sure we have smart and realistic goals for all of these. The sections that you will see that will not be completed are the Do Study Act, because that's kind of the end of your quality improvement project. So you will not see anything here. And your data collection and methodology, you may not see anything here depending upon if you put some rationale there of how you're going to collect and analyze the data. But if you're looking at the worksheets, this is kind of that 6-month period where you'll be monitoring that data and reporting it out. And so you'll see some more comments there once we get to the end of the project. So we're hoping this is going to be a little more of a succinct way of us giving feedback to you for your quality improvement projects. And really help out and lend itself to providing kind of some basic technical assistance on writing problem statements and looking at driver diagrams or, primary and secondary drivers, along with the way that you may be looking at your aim and rationale for those projects. We hope to have those to you by next Friday so that we have enough time to kind of converse and speak back and forth about that feedback. And Jennifer and my team will be coordinating that and circling back with the sub-recipients. Any questions about, you don't have them yet, but any initial impressions or thoughts that we like kind of the worksheet to give you feedback on, to kind of guide you in the process for that? Yep, okay. Awesome. I will jump back to that's really all I have for that. Let's go back to this screen. All right, let's bring this down. Oh, well, wrong button. Perfect. All right, back to you, Jennifer.
Thank you, Thomas. So we at the HRAU had our virtual site visit for HRSA and HAB for our Part C grant last month. So we are awaiting the final report. But I just wanted to let anyone know who is a Part C grant recipient that we will be doing some focus on clinical quality management for Part C. The hope is to incorporate it throughout all the grants, so it shouldn't be a really heavy lift, but chances are we will be meeting with Part C recipients to go over any QI projects, quality management, focused activities for Part C. So that is broken down as well. So I wanted to just kind of give you all a heads up about that, but we are waiting the final report.
Awesome. And if I can jump in there, Jennifer, and just kind of talk about what you and I talked about. So like then the initial impression is that HRSA would like us to have kind of a separate Part C CQM plan. We're not going to change any big indicators. We're going to continue on, but just making sure that those are separate from the Part A CQM activities so we can differentiate. Same projects, just 2 separate plans to look at different items. Is that correct, Jennifer?
That is correct, yes.
Awesome. All right.
Okay, so I guess I'm going to jump on in. I wanted to take some time today to provide a presentation for our client satisfaction survey that we worked on from December to March. It's pretty data intensive. So what I'm going to be presenting today is some of the findings that we had and some of the recommendations that we had for the medical visit, and focus on that so that we could save for time. I will be sending out individualized reports with all the information regarding all the modules for each of the service categories. But today I'm going to be focusing on an overview of the findings for the HIV medical visit. So I wanted to give you an opportunity to take a look at what our findings are, but the report should be out tomorrow, and I'll be sending it individually to you all with the individualized information and information regarding the service categories. Thank you, Raju. Can you go to the next slide, please? Okay. Next slide, please. And let's skip down to, there we go, to the study purpose. So the purpose of this study, it's pretty much a requirement through HRSA. It mandates that our Ryan White grant recipients implement clinical quality management activities that are aimed on improving client care, health outcomes, and patient satisfaction. And the purpose of this study effort was to implement a client satisfaction survey which evaluates the results among individuals currently receiving HIV services within the Ryan White care system. So patient satisfaction is an important measure of the quality of healthcare delivery. Clients with higher satisfaction often make important behavioral changes, including adhering more closely to medical advice and treatment and keeping appointments, and maintaining stable relationships with medical providers. Next slide, please. So the methodology. Next slide, please. Thank you, Raju. So the methodology used for this survey, the HRAU unit conducted the following tasks for the survey. We met with the 7 Ryan White service providers to discuss project goals, survey instrument elements, implementation strategies, and efforts to engage clients in survey process, survey sampling plan. We also reviewed previously conducted satisfaction surveys, developed a survey draft, and the survey instrument was available in English and in Spanish. HRAU provided training for each of the 7 Ryan White service providers regarding the electronic survey tool. And the survey was live electronically for clients' participation from December 1st through March 16th. Each client who completed the survey was offered a $25 Walmart gift card for their participation. And a total of 22 surveys were conducted in Spanish, with the remainder of the surveys were conducted in English. So the breakdown of what we used RSR reporting data for 2022 to take a look at the unduplicated client count for parts A, B, and C, and developed how many surveys we wanted to capture. And the hope was to get about 10% of the clients served within the survey. Next slide, please. Thank you. Demographically, I wanted to touch on the differences between the demographic information from our survey participants compared to the overall Ryan White clients with data from 2022. There were some differences that was noted, but this could be just related to the sample size of clients and the characteristics of our population here in the Austin TGA. By age, the respondents, the average age was 30 to 39 at 32.38% compared to the average range of 30 to 39% at 20.4% of all Ryan White clients in 2020. Next slide, please. Thank you. 56.9% of the clients surveyed in the TGA identified as males versus 72.05% of total Ryan White clients identified. 37.14 identified as female versus 25.9% total Ryan White clients identified as female. 1.9 identified as transgender male to female versus 2.1% total Ryan White clients, and 0.95% identified as transgender female to male, and 2.86 identified as non-binary. The difference, one of the differences that was between our clients surveyed and the total Ryan White clients was the option of identifying as other or non-binary, which that data was not captured for the total Ryan White clients for 2022. Next slide, please. Perfect, thank you. There was slight differences seen for race and ethnicity. 30.48% versus 46.6% identified as African American or Black within our service, our survey participants. 2.86 versus 1.2% identified as Asian or Pacific Islander. 32.38 versus 23.6% identified as Hispanic or Latinx. We had no participants who identified as Native American or Native Alaskan, with a small percentage of Ryan White clients identified at 0.5% total Ryan White clients. 30.48% of our participants identified as white, whereas overall it was at 26.4%. 3.81% identified as other, where total Ryan White clients for 2020 identified as 1.2%, which kind of mirrors our racial or ethnic demographics for the Ryan White TGA overall. Next slide, please. Thank you. Of the clients surveyed, 54.29% identified as heterosexual and 27.62% identified as gay or lesbian. 2.8% identified as pansexual and 1.9% chose not to disclose their sexual orientation. Next slide, please. When the clients were asked where do they receive their medical care, 39.9% stated that they're receiving their care with Vivint Health. 21.43% reported David Powell. 17.86% were with community action, 14.29 are with Kind Clinic, 3.57 with Ashwell, and 3.57 with ACE Healthcare Foundation. Next slide, please. Thank you. Clients reported when asked when their last medical visit was. Over 50% reported that they had their last HIV medical visit within the last month, where 26.12% stated they had seen the doctor within 1 to 2 months. 15.89% reported seeing a doctor within 3 to 6 months. So the data shows that clients were seeing their doctor majority within 3 to 6 months and less than a month. Next slide, please. Whoops.
I'm sorry, I have some technical issue. Just a second.
That's okay. No problem. Take your time, Raju.
Yeah, this my mouse is not. I have 3 different screens, so just.
If you need me to pop in and share mine, I'm willing to do that. That's not a problem.
Just a second. Share screen. Screen 2. Can you share? Can you see right now? Methodology?
Yes.
Where we were actually.
If you could go up, one slide. There we go. Thank you, Raju.
Okay, you are welcome. Sorry about that.
That is a-okay. Thank you. When clients were asked how long have you been receiving medical care at this clinic, 30.56 of the clients interviewed had been receiving services for 1 year or less. Conversely, 30.56% of participants reported receiving medical care for 5 or more years. So there was a big range between individuals who are new to their clinic and also a big range of clients who have been with their medical clinic for more than 5 years. Next slide, please. Thank you. When asked how they would rate their health today, 44% rated their health as good, 22.94 rated their health as very good, 20.18 rated their health as fair, 11.01 rated their health as excellent, and 1.83 rated their health as poor. So for the majority of the clients reported good, very good, or excellent when rating their health care, their health, excuse me. Next slide, please. Thank you. The clients were also asked about access to HIV medical care and what it was like when they called the clinic, what their experience was. 61.8% of the clients reported that they received the help that they needed, which is really good. 14.61% of the clients reported that they talked to several different people before talking to the right person. 15.73% reported that they were put on hold too long. And 5.6% said that they got a busy signal. But for the most part, it was really good to hear that 61.8% of the clients are reporting that they got the help they needed when calling the clinic. Next slide, please. We also asked them when they needed an appointment and they had to reschedule, were they able to get one soon enough to meet their needs? 40.76% reported always. Usually reported 25.93%. Sometimes reported 29.63%. Rarely was rated at 2.86%. Never was reported at 0.93%. And 2.7% stated that did not apply. Next slide, please. They were also asked if they were provided any information or education about the importance of maintaining their appointments. 66.36% reported always, 16.82% usually, 5.61% reported sometimes, 4.6% reported rarely, never was reported at 0.93%, and 5.61% of the participants reported that it does not apply. Next slide. Clients were also asked about weekend and evening telephone accessibility. They were asked if they needed care during off hours, evenings or weekends, if they were able to reach someone at the clinic who could help. 22.02% reported always. 20.18% reported usually. 15.6% reported sometimes. Rarely was reported at 9.17%, and never was reported at 11.02%. Participants who reported that this did not apply to them was at 22.02% as well. Next slide. They were also asked if they had a medical question, if they could get someone on the phone to help them. So we asked about telephone accessibility to HIV medical staff. 37.96% reported always. 25% reported usually. 24.07% said sometimes. Rarely was reported at 2.78%. Never was reported at 0.93%, and 9.26% of the participants stated that that did not apply. Next slide. We also asked about what it was like in their impression of check-in staff. So when asked, when I checked in and waited for my visit, the staff was unfriendly to me. 46.72% reported never. 14.68% reported rarely. 11.01% reported sometimes. 14.68% said usually. 8.26% always, and 4.59% said that this does not apply to them. Next slide. Clients were also asked, or participants were also asked, if they had accessibility of HIV educational material for them to read. 59.26% said always. 17.5% said usually. 13.89% sometimes. Rarely was rated at 2.78%, never at 1.85, and 4.63% of the participants said that that did not apply. Next slide, please. When asked about their medical visit wait time, they were asked if they were ever upset about how long they had to wait for their medical appointment. 1.83% said always, 9.17% said usually, 22.94% said sometimes, 27.52% rarely, 35.78% of the clients reported never, and 2.75 said it didn't apply. Next slide. Patient complaints. We asked them, if their experience, if they had any complaints. So they were asked if they had a complaint about their medical care. They were asked if their providers would ignore it. 0.9% said always, 10% said usually, 8.18% said sometimes, 17.27% said rarely, 51.82% said never, and 11.82% of the participants said that it did not apply. Next slide. They were also asked about any interruptions they may have during their medical visits. They were questioned, when I saw my providers, my visits got interrupted by phone calls, other patients, etc. 1.89% said always, 11.32% said usually, 11.32% said sometimes, 13.21% said rarely, and 56.6% said never. 5.66% of the participants said that that did not apply to them. Next slide, please. They were also asked about any information they may receive about viral loads. So they were asked, my providers made sure I understand my lab results such as CD4 and viral load. 61.32% of the participants reported always. 24.53% of the participants said usually. 6.6% said sometimes. 3.77% rarely. 0.94 said never, and 2.83 said it did not apply. Next slide, please. They were also asked about their time spent with the providers. So they were questioned. The question was, I wanted my provider to spend more time with me. Of those surveyed, 6.54% said always. 13.08% said usually, 32.71% sometimes, 22.43% said rarely, 17.46% said never, and 7.48% reported it does not apply. Next slide. The patients were asked about if they had any questions related to HIV. And the question was, if I had questions I wanted to ask my provider about my HIV care, but I didn't ask if there was any questions. They want to ask their provider about my HIV care, but they didn't ask. 7.41% said always. 11.11% said usually. 21.3% said sometimes, 14.44% said rarely, and 37.04% said never. 3.7% said it did not apply. Next slide. Participants were asked about how comfortable they were with their HIV provider. And the question was, I felt uncomfortable talking about personal or intimate issues with my provider. Of the responses, 20.8% said always, 10.28% said usually, 11.21% said sometimes, 23.36% said rarely, and 45.79% said never. Of those respondents, 6.54% said it does not apply. Next slide, please. Patients were also asked about HIV medical decision-making. And the question was, I wanted to be involved in making decisions about my healthcare. 28.3% said always, 23.58% said usually, 15.09% said sometimes, 10.38% rarely, and 12.26% said never. 10.36% of the participants said it did not apply. Next slide, please. Clients were also, or participants were also asked about HIV education comprehension. The question was, when I asked my provider questions about my HIV care, it was hard to understand these answers. Of the answers, or 4.72% said always, 6.6% said usually, 17.92% sometimes, 20.75% rarely, 46.26% of the respondents reported never, and 3.77% said it does not apply. Next slide. Clients were also asked, or participants were also asked about the empathy of their providers. The question was, I found my providers to be accepting and not non-judgmental of my life and healthcare choices. Of the respondents, 49.06% reported always, 20.75% reported usually, 11.32% sometimes, 8.49% rarely, 7.75% never, and 2.83% reported that it does not apply. Next slide, please. Accessibility to HIV prescriptions. Participants were asked the question, it was hard for me to get my HIV medication prescriptions filled when I needed them. Of the respondents, 1.9% reported always, 6.67% said usually, 18.1% said sometimes, 25.71% rarely, and 40.95% said never. Of the respondents, 6.67% said it does not apply. Next slide, please. They were also asked about HIV medication side effects education. And the question was, my provider explained the side effects of my HIV medications in a way I could understand. Of the respondents, 51.89% said always, 21.7% said usually, 14.1% sometimes, 3.77% rarely, never was reported at 2.83%, and does not apply, 5.66% of the respondents reported it does not apply. Next slide, please. They were also asked about HIV medication compliance education. The question was, my provider suggested ways to help me remember to take my HIV medications. Of the respondents, 82.86% reported yes. 7.62% reported no, and 9.56% of the respondents were unsure. Next slide, please. They were also asked about medical test education. So the question was, my providers explained what kind of medical test I should be getting and how often I should get them. Of the respondents, 80.9% said yes, 11.43% said no, and 7.82% were not sure. Next slide, please. They were also asked about if providers explained to them how to avoid getting sick. Of the respondents, 80.58% said yes, 7.77% said no, and 11.65% were unsure. Next slide. They were also asked about transmission prevention education. So the question was, my providers talked to me about how to avoid passing HIV to another person. Of the respondents, 89.52% said yes, 5.71% said no, and 4.76% reported that they were unsure. Next slide. Participants were also asked about receipt of Hep C education. The question was, my providers talked to me about how to protect myself from getting Hep C or how to avoid passing it on to others if I already have it. Of the respondents, 80% said yes, 9.52% said no, and 10.48% said that they were unsure. Next slide. They were also asked about housing or emergency financial assistance referrals. And the question was, my providers or case managers asked me about my life situation, housing, finances, etc., and made a referral if I needed help. Of the respondents, 83.83% said yes, 11.43% said no, and 4.76% said that they were unsure. Next slide, please. They were also asked about behavioral health referrals. The question was, my providers or case managers asked me how I was feeling emotionally and made a referral to mental health provider, counselor, or support group if I needed it. Of those surveyed, 79.05% said yes, 11.43% said no, and 9.52% of the respondents reported that they were unsure. Next slide. They were also asked about dental referrals. The question was, my providers asked me about my teeth and made a referral if I needed to see a dentist. Of those respondents, 76.92% said yes, 14.42% reported no, and 8.65% reported that they were unsure. Next slide. They were also asked about nutritionist referrals. The question was, my providers asked me about how I was eating and made a referral to a nutritionist if I needed help. The respondents, 74.09% reported yes, 17.31% reported no, 8.65% reported that they were unsure. Next slide. They were also asked about partner disclosure referrals. The question was, my providers asked me whether I needed help to tell my sexual partners about my HIV status and make a referral if I needed help. Of those respondents, 64.42% said yes, 27.88% reported no, and 7.69% reported that they were unsure. Next slide. Also asked about referrals for alcohol or drug use. The question was, my provider asked me about my drug and alcohol use and a referral if I needed help. The participants, 78% reported yes, 15% reported no, and 7% of the respondents reported that they were unsure. Next slide, please. They were also asked about how accessible the referred services were. So the question was, I was able to get the services that my provider referred me to. 3.85% said that it did not apply to them. 45.19% reported always. 29.81% said usually. 14.42% sometimes. 4.81% rarely. 1.92% reported never. Next slide, please. So the participants were then asked if they were not able to receive the referred service, what was the reason? So the question was, if there were times you did not get the services you referred to, please describe the reasons. So these are some of the answers that the participants reported. Homelessness, housing services, no insurance, insurance. I have no insurance and limited money. Sometimes I felt the doctor was not caring enough. She didn't get back to me yet. They've been really busy. Insurance, physicians referred to staff never call back. No referral for my osteoporosis due to insurance issues. In some cases, the programs that are funding the assistance have long wait lists. Not seeing new clients or the wait time too long. Help with housing has been rough. At times, it seems I don't get the help I need when it comes to housing. They don't take my health insurance, could not afford co-pays, and there are no services that pay for co-pays up front. My doctor's offices require payments at time of visits. So majority of them reported issues related to no medical insurance or underinsured, issues with affordability of co-pays, and long waiting services for select services, markedly housing assistance programs. Next slide, please. They were also asked how they would rate their providers' knowledge of the newest developments in HIV medical standards. Of the respondents, 46.15% reported excellent. 35.58% said very good. 10.58% said average. 2.88% fair. No one said no percentage for bad. 4.81% reported not sure. Next slide, please. Participants were also asked, when I think about my care at this clinic, these words come to mind. 41.5% reported excellent, 22.64% adequate, 0.94% said okay, 0.94 poor, 0.94 busy, 4.72 reported personable, 1.89 said caring, 1.89 friendly, 3.77 reported safe, 1.89 rush, 0.94 impersonal, 1.89% reported dignified, 8.49 respectful, 0.94 said humiliating, 5.66% understanding. So for the majority, 41.51 reported that they thought their HIV care was excellent. Next slide. They were also asked to rate the quality of care of that specific clinic in comparison to other clinics that they know about. 48.11% of the respondents reported much better, 36.79% said better, 10.38% the same, 1.89% said worse, 0% said much worse, 2.38% responded as not sure. Next slide. Clients were also asked if they would recommend this clinic to any HIV positive friends with similar needs. Of the respondents, 72.64% said definitely yes, 25.46% maybe, 1.89% definitely no, and no respondents reported that they were unsure. Next slide, please. Clients were also asked about their perception of any unsatisfactory treatment, and the question was, at any point did you feel like you were treated poorly at this clinic? Of the respondents, 85% said no, 15% said yes. Next slide, please. So of those that reported perceived reasons for unsatisfactory treatment, the question was posed to them, please help us understand why by checking any of the reasons you feel may have caused you to be treated poorly. Of those who responded, of the 13 responses, 7 of the responses reported that they didn't have any mistreatment, making the response disproportionately high. Other responses were calling in for appointments. An operator hung up on me. One person responded that. I guess that's how the staff are generally, was one response. They're good was another response. I would sometimes get pushback from pharmacy staff when I'd come to them for help with bridges in between refills of a medication, was one response. And then there was 4 individuals who responded with NA. Sometimes the clerks have a little attitude when picking up meds, but it's way better now, was another response. One person responded, my English. Another person responded, never, I get the best care. That was one response. Another person reported, treated me fairly all the time. So 15.15 said my race, same for age and drug use. 3.03 responded my gender, 9.09% my sexual orientation, 3.03% reported immigration status, no responses for difficulty speaking, and 39.39 reported other, which was explained with the individual responses. Next slide, please. They were also asked about services in their preferred language. So they were asked, I got services in the language I want. 71.43 reported, 71.43% reported always, 20% usually, 5.71% sometimes, no respondents for rarely, and 0.95 for never. Next slide. Clients were also asked, or participants were also asked about their affordability of care. So they were asked the question, I did not get the medical care I needed because I couldn't pay for it. Of the respondents, 11.43% said it does not apply, 2.86% always, 7.62% said usually, 9.52% said sometimes, 14.29% rarely, 54.29% said never. Next slide, please. They were also asked Participants were also asked if they ever thought about changing providers. So the question was, I thought about leaving this clinic to find better care somewhere else. 4.76% said it does not apply. 4.76 said always. 7.62% said usually. 16.19% sometimes. 14.29% said rarely, and 52.83% said never. Next slide, please. Thank you. They were also asked about confidentiality. The question was, the staff and my providers keep my HIV status confidential. 68.57% said always. 15.42% said usually. 4.76% said sometimes. 4.76 rarely. Never was reported at 2.86%, and 3.81 reported none of the above. Next slide. They were also asked and posed the question, what would you add or change to make the clinic a better place for yourself and other patients? So their individual responses were captured in the next few slides. So the responses were, there needs to be someone knowledgeable about healthcare plans, a more discreet check-in, housing services, need a new medical supervisor. Some of the staff are unfriendly, able to make appointment changes instead of always calling in on my chart. Some staff are bad. There needs to be a little more communication with the patients, friendlier pharmacy staff, just to opening backup groups. I think by face-to-face groups will help a lot. Doctors continue to study and prepare more every day about HIV. Maybe more bilingual staff, better parking. Some staff need to be changed. They need to be considerate of patients' time. If you book a time, we deserve the same consideration as they're 15 minutes late, we have to reschedule. If they're late, sometimes an hour, they expect you to wait until they get to you. Change the wait time for labs, which tend to be long. Next slide. Thank you. And more responses were as follows. Excellent place. Everyone is always very friendly. I will change the time of waiting for a concrete and fast resolution to any required need. My recommendation, 1, please do not mail any letters to the address at random, as the envelope will have a logo on it, which will cause a nuisance to my privacy. 2, for the monthly medication delivery, could the pharmacy's name and logo not appear, as my mail is received by the landlord on my behalf, which could cause me distress. Better hours for people to work 9 to 5 jobs. Don't call your full name in a full waiting area. Again, not call out full names in the clinic, or when doing blood work, can ask after we approach them. Nothing. I like this clinic. Hand scanners at check-in that work with Epic MyChart and better parking. Just to know to date information on HIV, and have a lot more paid opportunities like classes. Keep up the good work. Nothing. The staff is amazing. Next slide. A few more recommended changes. A little more spacious. Nothing. They treat me like family. Case manager neglected to return my phone call. More friendly staff. Some way to check the status of THMP, Ryan White, and PAP, so I don't have to rely on letters to stay up to date. Better answering service, faster service. Next slide. And a little more feedback. Excellent. Everyone is wonderful. Was very quick helping me get the medication I needed. Nurses were wonderful. No, my doctor is very well prepared and up to date on HIV. Confidential always. You're doing a great job, and I appreciate your help to each other. Dr. Crow is amazing. Again, Dr. Crow is amazing and explains in detail. Next slide, please. More feedback. I love the care. I felt pressured to switch my current pharmacy to the clinic's pharmacy. Dr. Zachary is the best provider that I've worked with anywhere. I not only feel like we're partners in my health, I've come close to calling him my friend. Thanks so much. I will always go to them. They're very respectful, nice, friendly, and courteous. So grateful, not sure what I would have done without all the care and love from Kind Clinic. A good clinic, nothing but doctors and medical assistants, and they all have treated me great. And a little more feedback. Next slide. Excellent service, very good by the visits, but the visits are too long. Great place to be cared for. Better location, deliver medications, good service. Next slide. Clients were also asked about their level of support. The question was, I have family members, friends, or professionals who give me a lot of support. 38.10% strongly agree, 47.62% agree, 11.43% disagreed, and 2.86% strongly disagreed. Next slide. So the overall findings when we took a look at those surveys and data from the HIV medical care, survey demographics had some variances which differed from the overall Ryan White client demographics, which could be explained by the overall demographic makeup, the Austin TGA. Additionally, the survey inquired more inclusively regarding sexual orientation and gender to include pansexuality and non-binary options. Overall satisfaction ratings throughout were high for customer service and for access and availability of services at the Ryan White funded agencies. 81.73% of respondents rated their provider's knowledge of newest developments in HIV standards are very good or excellent. 30.56% have been in care for 1 year or less, while 31.48% have been in care for more than 5 years. On average, 75.92% of respondents have received referrals for additional support services. 72.64% of respondents would refer others to the HIV service agencies. 82.86% of all respondents indicated the HIV staff has provided them with ways to help them remember to take their HIV medications. Next slide, please. So 66.67% of respondents reported they could schedule an appointment soon enough to meet their needs. 50.47% of all respondents reported having an HIV medical appointment within the last 30 days. 80% of clients said their HIV doctor has talked to them about how to keep from getting hepatitis C or how to avoid passing it to others. 80.9% of clients reported that their HIV providers explain what kind of medical tests they should be getting and how often. 89.52% of respondents reported their HIV medical provider discussed with them methods to avoid the transmission of HIV to their partners. Next slide. 71.43% of respondents reported receiving services in the preferred language. 70% of all clients interviewed rated their general health as excellent, very good, or good. And 76.85% of respondents reported HIV-related materials were available for reading in the HIV medical clinic. Next slide. So when it comes to quality improvement recommendations, the following recommendations include enhanced communication from doctors and provider staff to clients regarding improving evening and weekend telephone accessibility for patient communication. 21.18% of respondents reported difficulties reaching staff on weekends or evenings. Improve hold times for client telephone calls. 15.73% of respondents reported being on hold too long, whereas 5.62 reported receiving a busy signal, and 14.61% reported the phone rang too long before it was answered. Additionally, 14.61% of respondents reported talking to several different staff before reaching the right person. Improve wait time for HIV medical appointments. 33.94% of respondents reported concerns over wait times for the HIV medical appointments. 1.83 as always, 9.17 usually, and 22.94% sometimes. Improve the amount of HIV medical visit interruptions. 37.74% of respondents reported some interruption with their HIV medical appointments with their provider. Next slide, please. The improvements also include improved referral follow-up for housing, financial, alcohol and drug use treatment, behavioral health, nutrition, dental, partner disclosure support. 21.15% of respondents reported issues with obtaining referred services. Improve availability of HIV medication prescriptions. 26.67% of respondents reported difficulty with getting their HIV medications filled. Doctors are doing a great job of communicating with the patients. However, it's important for doctors to have frequent, clear communication with clients regarding keeping their appointments, importance of taking HIV medications, how to keep from passing HIV along to others, how to protect them from getting HIV or Hep C, excuse me, importance of being virally suppressed or undetectable. Last slide. So I just wanted to touch base a little bit on some of the challenges and recommendations, and this is more so for, quality improvement process with conducting these surveys. I noticed there was a low number of surveys that were completed. We're hoping to obtain over 300 participants, and I think we had a little over 100 participants, which could skew the data and not be really representative of a percentage of our patients. So what I would like to do in the future is coordinate with you guys for more in-person service conduction, and possibly talking about a timeline where we could keep the survey live for the clients. So it's both hybrid where they're assisted, but also live for a certain amount of time within the year. There was also some issues with challenges with the gift cards. Some clients didn't receive them. Some reported zero balances. Some participants did not provide any information on the gift card page to be able to give them the gift card. So I think it would be easier moving forward to eliminate some of those challenges, to do one or the other, leaning more towards physical cards, specifically if we're doing in-person at the clinic. It would be easier for them to receive physical gift cards at that time. Survey was too long, as you see. I've been speaking for a long time, and that's just the HIV medical care. And then we have it broken down in modules for all of the service categories as well. So what I'd like to do moving forward is coordinate with you to establish, really intentional questions and streamline the service per service category. So meeting with staff members from case management or food bank to discuss what information we should capture and be really intentional, and so that we're able to meet the clients where they're at and not overload them. but still capture, necessary and valuable data. Another one of the challenges that I noticed was, not a challenge, but just a reflection. There were some questions that were missing related to linkage of care, retention of care, reasons for times when they were out of care, and knowledge and access to PrEP. So again, when reviewing and restructuring the questions for the next survey, I think it would be important to address linkage of care, retention of care, and also include questions where we're able to extract data on our focused priority populations. All right, so that's what I have. So I'm all done with that. I wanted to open it up and see if anyone had any questions regarding the presentation or any information I provided. Okay, perfect. So what I am going to do now is I am going to pass it over to Raju. And I'm going to share my screen.
Good morning. I'm not sure what is the allotted time for the meeting today.
Yes, sir. So we have probably about 15 minutes left.
Okay, my presentation won't go that long, but I'll try to finish in 10 to 15 minutes because this is a simple document. Okay.
Okay.
Okay. Thank you, Jennifer. So today I'm going to cover some of the highlights of Rapid Start service standard that SRAU prepared. So we'll also share the document with you all. And we also expect the review and feedback from all the providers and other stakeholders as well. The purpose of this document is to provide guidelines and set a minimum standard of care between providers and set clear expectations and minimum requirement for the rapid ART programs. So this could be like subrecipients integrating the rapid ART standards and protocols into their clinics and having their rapid ART protocol in place that meets the standard of the jurisdictions. So this document is also expected to help providers to create and strengthen their rapid ART activities in their facilities and communicate the benefit of rapid ART in order to promote and expand the rapid ART in adoption in future. So these are the contents that we'll cover today. What rapid ART is, the rationale for the rapid ART and programs, goals and objectives, and intake and eligibility process, rapid ART workflow, and how the rapid ART are prescribed and use of starter pack and linkage to care process, and finally performance measure and reporting. Next slide, please. Okay, what is rapid ART? Rapid ART is starting antiretroviral therapy immediately after the HIV diagnosis, preferably on the same day in the first clinic visit. So some of the jurisdictions have their own definitions. Some of the providers have also their own definition for the rapid ART based on the time period they can provide the rapid ART to the clients. It can be the same day or 3 days or maximum of 7 days. So you can define your time period, but our standard of time period is basically 3 days or within 72 hours of the new HIV diagnosis. So here are some of the rationale for the rapid ART. It can result in earlier SIV viral suppression, improve retention and care, and reduce SIV transmission. This is also a health equity issue because a RapidR should be available immediately to all the people, regardless of race, gender, ethnicity, or other factors. And also, this is recommended by the US federal guidelines. Next slide, please. So what RapidR can do for the patient? Actually, the RapidR patient can get medication sooner, ideally on the same day. So viral load will be suppressed more quickly. So it also reduces client doubt about their ability to get medications. And they will also understand what U equal U messaging, in the meaningful way, and more likely to make their first HIV, specialty care appointment, and it will help build the trust relationship between the clinic or providers and the clients. So it will help eventually retention and care in future. The next slide, please. So what RapidR can do for the clinic? Actually, it will help better patient outcomes for the clinic, more empowered relationship between patient and staff trust, and potential efficiency of clinic operation, making use of no-show slots. You can use the time very efficiently, and it can also be cost effectiveness if we can cooperate with different pharmaceutical companies and other resources available. And clinic staff enjoy adding a new service to their skill set and fewer visits to initiate someone on RapidR. And there will also some benefit to the EHE jurisdictions like HRAU, Austin Public Health. It will help to meet the pillar 2 goal, promptly linking individuals newly diagnosed with SIV to care and treatment. And it will help address the health disparities as well. Next slide. So the goal of the RapidR is actually to provide medications to newly diagnosed clients within 72 hours of their new HIV diagnosis, or if possible within 24 hours. But our standard at Austin Public Health is at the moment 72 hours, but some of the providers are providing RapidR within the same day in the very first clinic visit. So our objective is to link 95% of newly diagnosed clients, including priority populations, to RapidR within 72 hours and achieve 95% of viral load suppression by February 2025. Next slide, please. So, person appropriate for the RapidR, who should receive the RapidR? Nearly all individuals with confirmed new HIV diagnosis, and also person with positive result of RapidR antibody test before any confirmatory test results are available. And if the concern for HIV infection is high, after counseling, immediate ART can be offered with the understanding of if confirmatory tests are negative and the patient should stop ART. We can discuss, and you can provide feedback on this point. There are some contradictory comments whether we can provide the RapidR without confirmatory test. Before the confirmatory test, the patient SIV result can also be negative. So the next point is the RapidR is not appropriate for patients or person with certain untreated opportunistic infections, for example, like cryptococcal or TB meningitis. So we need to begin the treatment, for those other opportunistic infection before starting any ART or RapidR. So the patient should consult with physician, nurse, or practitioner, or any other expert. Next slide, please. What are the intake and eligibility process for the RapidR? Actually, any individuals with preliminary HIV positive test result is eligible to receive the RapidR services. So there is no requirement that individual meet the eligibility for any Ryan White HIV/AIDS programs to receive EHE services, specifically the Rapid ART. So there are no other jurisdictional restrictions for EHE eligibility except the HIV positive test result. So clients can receive Rapid ART immediately after HIV positive diagnosis. Next slide, please. So here is the Rapid ART workflow. We can see here the step-by-step process from the testing to the Rapid Start prescription. Okay, so this is actually for those who have diagnosed in the offsite testing site link and on-site. There are basically two sites, offsite and on-site. For those who have diagnosed in the offsite, the testing site should immediately contact with the Rapid ART provider by either the referral services to set up an appointment. And if the client tested in on-site, they will begin the Rapid ART process and will link to HIV care. And the Rapid ART start visit at the very first stage, the client is greeted by any designated staff in the clinic, for example, like linkage coordinator, nurse, or other staff, and start the Rapid Start visit. And the next step is the intake and insurance enrollment. The case manager or any patient navigator, counselor, social worker will initiate the insurance and benefit eligibility and enrollment process and complete the intake assessment. And then client will move into the clinical exam, and the doctor or nurse practitioner will prescribe ART after some basic lab works. Next slide, please. And then after the baseline labs, clinician order the labs for the client for the confirmatory testing, any blood work to establish baseline health for the patients. So patients should usually walk to the blood turn side. And then the next step with the same day ART prescription and provision. And the other support services will also be provided to the clients, either a referral to support services, for example, food, housing, mental health services that must be addressed concurrently to the medication process access. And finally, the follow-up visit after the Rapid ART prescription. The linkage coordinator or any other designated staff should follow up the clients within the 1 to 2 weeks after the Rapid ART prescription or starter pack. Next slide, please.
Raju, can I interrupt, please?
Yes.
We are really out of time. Can we maybe send the PowerPoint out and the document and ask people to review this and get their comments back to us by maybe, I don't know, the next Wednesday or so. I'm sorry to cut you off, but we really are out of time, and we've got 2 more things that we really need to cover really quickly.
Okay, sure, we can do that, Ken. I have the document in the Word document of the Rapid ART service standard. We can share the Word document with all providers and then receive feedback. That is fine.
Okay, thank you, Raju.
Sure.
I'm sorry to
You're
cut you
welcome,
off.
no problem.
All right. And so really quickly, our last 2 items is we have a Lean Six Sigma Yellow Belt training that will be offered to our single points of contact for CQM. We are currently working with the recipient's office. We have a plethora of dates that range from October to December. And so we will be coordinating with recipient's office to pick a handful of dates. And then we will kind of come back to the committee via email and via a voting poll to see what dates work best for everyone. So be on the lookout for that. We will send you an email kind of solidifying what those dates are. That's a full day of training from 8 in the morning to 5 in the afternoon. It is you will get your yellow belt certification in Lean Six Sigma. The caveat to that is you do have to pass a little bit of a test at the end. All the information is given to you during the class. It's a great instructor. I learned under this instructor. Derek learned under this instructor. Very easy to follow and is not kind of in the industrial area. This will be leaning itself directly to Ryan White Clinical Quality Management. So we won't have to worry about, you'll learn about Kanbans, but you won't learn about how to make your workspace better in an industrial area, right? So we made sure that this was kind of engaging for what we do and specific to what we do. The final piece, I'll turn over really quickly to John and Octavio to discuss People Purpose Power Conference, what's coming up. If you don't mind, I'm going to leave the screen up. So if you haven't registered as they're talking, you can scan this QR code on your screen at the bottom right, or you can use that document I attached to this agenda as well. So John, Octavio.
Great, thank you. Hello, everyone. So we are hosting, on behalf of the Ryan White program, People Purpose Power. It is a free one-day conference for HIV care and prevention providers, program staff, planning council members, and people with HIV. The presentations are geared more towards service delivery. So for those folks who might be folks with HIV, it may be interesting, but it is not specifically directed towards improving, like specifically addressing their healthcare needs, mental health needs, empowerment, what have you. The presentation lineup, we are working on that now, but I will tell you that we have already confirmed great presenters related to trauma-informed care, both from a perspective of providing service, but also trauma-informed self-care, some innovative prevention initiatives, rapid start initiatives, and other content. We will be confirming the agenda with Ken and his team shortly. The event will take place on Friday, July 21st at the City of Austin Permitting and Development Center, and I've got that address information going into the chat now. You also have the flyer, and when you go to the registration site, that information will be there as well. This is a free event, and I will let Ken talk about who he was hoping would take part in the event and his expectations around that in just a moment. I will say that this will be a dynamic, great event. And if you have staff that aren't able to go to Ryan White conferences or the US Conference on HIV and AIDS, this will be a wonderful opportunity for them to attend presentations on personal growth, professional development, service innovations, and ways that we can provide greater service than you already do to people with HIV. And Ken, maybe I'll just put you on the spot and let you talk about who you would like to attend and those expectations.
Yes, thank you, John. So real quickly, I would like agency staff, agency executives, clients to all attend this this symposium. And you may have noticed in your Exhibit Ds in your contracts that there is a training requirement. This will satisfy at least part of the training requirement that we not only ask, but mandate in your contract that you have. So please circulate this, get people registered now. I mean, we need your staff, at least clients that are interested in attending at least, and other community members that you may know. So we will have a cutoff of 150. So you need to get your registrations in early, which means like now or yesterday. So we can plan, and so you can make sure that you get into this. It's going to be a great day, and it's going to just be a wonderful time, not only to learn things, but to network with your peers.
And we will serve breakfast and lunch for the event. And we really are looking forward to seeing you and your staff there. I think you will really enjoy this conference, and we're excited to present it for you.
So I think we're done.
Yes, sir. I dropped all of the save the dates and into the chat. So if you need that and you want to distribute that flyer, please do. And let us know how we can help you be successful in getting people enrolled. So we're here to help. If there is nothing else, we appreciate everybody joining us today, and look forward to sending out that feedback for your quality improvement projects by next Friday. And if you have any questions, sorry, it feels a little rushed, but trying to get everybody back on schedule, let Jennifer or I know, and we'll make sure that you get what you need. So thank you, everyone. Have a great rest of your week. We look forward to seeing your names come across the registration for People, Purpose, Power in July. Have a great week.
Thank
Bye,
you.
everyone.
Thank you.